Can you see my screen? Okay, so once again, good morning. Let me introduce myself first. My name is Asif Iqbal. So let me share with you my brief profile. I have done my master's in organic chemistry in 2001. Then I joined SNIBE. I have done my master's in 2001. And after spending in 1 year in training in one of the prestigious CAP accredited, JCI accredited institutes in Pakistan, Khan University Hospital Laboratory, as a medical technologist. After spending in 4 years as a technologist, then I got an opportunity in the Roche Diagnostic Division of Pakistan, where I have started my career with an application specialist, then assistant customer support manager, and then I was promoted as a product manager for the centralized diagnostics between the duration of 2007 and 2013. So I've spent around 7 years in a Roche Diagnostic Division, and then I have got an opportunity to join Abbott Diagnostic Division in Pakistan as an application manager and NPS coordinator, along with the quality representative for the consortium audit of Abbott Diagnostic Division in Pakistan. So, being an application manager and NPS coordinator, I was responsible for these countries like Sri Lanka, Bangladesh, Maldives, and Afghanistan. So then I got opportunity in SNIBE. So I joined SNIBE in April 2023, 24th April, and I'm working currently as a training manager consultant for Asia for SNIBE Diagnostics, and my reporting is to Ziv and Zui. So this is a whole brief description about myself. So let's start with the presentation. So you can see my screen for the SNIBE regular gonadal panel. So you can see my screen. Okay, Malia and Ivan Lifar, thank you very much. So today we have to change a little bit. If I'm going fast, please let me know I'm going fast. So if you need a slow pace training, I can make my pace a little bit slow. Or please ask questions. Don't worry about if you ask some basic question. It will not be a bad thing. It will be a good thing for us, so we have to be clear our concepts. So if you have any silly questions, you can ask me at any time. Like, for example, when we are in beta hcg, you can ask what is the difference between a serum beta hcg and the urine beta hcg. So these are the basic questions. If someone wants to make clear the concept about these things, so they can ask me at any time. Okay, so it will be good if I receive more questions from your side. It will be great, and it will be a great experience. And during this training, I will also share with you my experience for different analytes, good laboratory practices, and what are the regular and the target utilization of these infertility panels or the regular gonadal panels in IBD market, right? So let's start with the SNIBE regular gonadal panel. So we have a three part in this presentation. If we talk about the first part contains the background. In the background, we will discuss about the HPG, hypothalamus pituitary gonadal axis. And then in the first part, we will discuss about the fertility parameters, plus the secreting tissues, the menstrual cycles, and the pregnancy hormonal change, menopausal, and the essay like DHAs, and for the each essays clinical application we will discuss in this part one. In the part two, we have a common gonadal diseases discussion. In this, we will especially discuss about the hypogonadisms in the male, precocious puberties, ectopic pregnancy, and the miscarriages, and the polycystic ovarian syndromes, and prolactinemia, and the other diseases which are related to the gonadal diseases. So in the last part, part three, we will discuss about the SNIPE solution from the Meglumi platform, what they are offering for the gonadal disease management and the prognosis in this part, like LH, FSH, prolactin, testosterone, progesterone, estradiol, beta ICG, DHA, and the gonadal menu, which helps to diagnose different gonadal diseases. Okay. So let's start with the first background. So in this first part, we have to discuss about the hypothalamus pituitary gonadal axis. So as you know that this hypothalamus, which lies just close to the pituitary gland in the brain, and it's involved a complex interaction between the hypothalamus, pituitary glands, and the gonads. So this all these tissues and the glands which involve for the production of gonadal hormones, that we call them hypothalamus pituitary gonadal axis, or HBG axis, like HBG axis, right? So this system works together to regulate the development. And as we know that this hypothalamus is basically release the pituitary that's release some stimulating hormones like gonadotropin releasing hormones to act on that pituitary gland. And this pituitary gland has two parts. The one is the anterior part and the second is the posterior part. And you know that the posterior part release different hormone, while the hypothalamus is a neutral tissue. So this hypothalamus, which is a neutral is basically neural tissues which conversion between the pituitary gland, conversation between the pituitary glands and hypothalamus through the nerves occurs. So through the nerves, they release the gonadotropin releasing hormone, and then these pituitary hormones have stored two hormones like oxytocin and ADH in the posterior part. And the anterior part is responsible for the releasing of different hormones. That's the TSH, prolactin, thyroid stimulating hormone, LH, ACTH, and growth hormone. So especially for the hypothalamus pituitary gonadal axis, that's hypothalamus trigger the gonadal releasing hormone to the pituitary glands, and the anterior part of that pituitary gland release the LH and FSH. And the LH has an impact on the Leydig cells, and this Leydig cells release testosterone. So while this FSH, which is released from the anterior part of the pituitary gland, it's has stimulate the serotonin cells, which used to release some androgen binding globulin and inhibitions, other tests. So again, And this is the male hypothalamus pituitary gonadal axis. In the female, there's a difference when the gonadotrophin releasing hormone have an impact on the pituitary glands. It's released the LH, and then the LH has work with the ovaries, and then the ovary release the estrogens, and then the FSH also has an impact on the ovaries to release the inhibitions process. So this is the process of hypothalamus pituitary gonadal axis, which involves in the male and the female to release or trigger the tissues to release the different hormones for the regulation of the gonadal functions. So you can see here the more detail about this. This is the lobular area where the pituitary gland axis, and just close there is an hypothalamus, and then this opticism anterior part, which as we release lactotrophins, then the prolactin as well. So that's the prolactin helps to release the breast milk in the women's, and then it's also gonadotrophs also release some luteinizing hormone, that follicular stimulating hormones, and these both have an impact in the female on the ovary to release the estrogen, and then follicular stimulating hormones has an impact on the testosterone, releasing using this testis. So this is the role of pituitary gland, and this through this cycles in a male and female, they release the different hormones. So when you go for a regular fertility parameters and then release secretory tissues, it's an important part. You can see that what hormones are released by which glands or the tissues, or what are the matters. So what are they are chemically what they are. So if you talk about the LH, FSH, and prolactin, these three hormones are also called the fertility regulatory hormones, and the source is the pituitary gland. So on the stimulus on the hypothalamus, they release the pituitary gland anterior part release these hormones like LH, FSH, and prolactin. And LH and prolactins are glycoprotein in nature, while the prolactin is protein in nature. So if we talk about the other, in which the HCG, estradiol, progesterone, and the SHBG, they are also releasing through the placenta. And in estradiol is also releasing with the from the ovary along with the placenta, while the SH binding globulin release is in a small quantity from the liver, uterus, testis, and the placenta, while the progesterone along with the placenta, corpus luteum is also released to have to maintain the menstrual cycle, or make sure that the ovaries prepare for this expected pregnancy. So these hormones like beta HCG, they are glycoprotein in nature, while the estradiol, progesterone, testosterone, and DHEAS, these are steroidal in nature. If you talk about the SHBG, this is also a glycoprotein, but the DHAs SO4 source is the testis or the adrenals, and this is basically a steroidal hormone. So these are the basic hormones source from where they are producing and the chemically what they are. So if we talk about more, so let's go to the cycle in which we have talk about the menstrual cycle. So as we know that in a menstrual cycle, there is a stage of three stages. One is called a follicular phase, ovulatory phase, and the luteal phase. So you see that there are three cycles review in the menstrual cycle. One is the pituitary cycle, other is an ovary cycle, and the third is endometrial cycles. So you know that is a series of change, natural change in the hormones. You see here production and the structure of the uterus. You can see here the structure of the uterus and the ovaries for of the female reproductive system that makes the pregnancy possible. So let's talk about one by one the hormones. So if we talk about the FSH, basically FSH is called follicle stimulating hormone. The basic function of this follicle is to initiate the follicular growth and the development, right? So the main function of the follicle stimulating hormone is to initiate the follicular growth and the development. The second hormone is LH. So you can see that at the ovulatory phase, the highest peak value of LH is acquired, and it's acute rise of LH trigger ovulation. So this ovulation is triggered by the acute rise of luteinizing hormone and the development of the corpus luteum. So the main function of the LH is to the release of the triggered ovulation and the development of the corpus luteum. So if we talk about the estradiols, that's the third hormone that's used for the menstrual cycle maintenance in the ovarian cycle and the pituitary and the endometrial cycles. This estradiol has a positive feedback mechanism to the pituitaries and make it more responsible for the gonadin releasing hormones. So the main function of the estradiol is this. So if we talk about more the fourth fertility hormone, that is progesterone. Basically, the progesterone is usually secreted by this corpus luteum, and when it's losing, it's when it's in the ovary. So during the second half of the menstrual cycle, this is the second half of the menstrual cycles, and then it's play important role in maintaining the early stage of pregnancy. So the progesterone and the beta hcgs, when the pregnancies occurs, then the conceive occurs, then they play a very vital role. The progesterone and the beta hcg play a very vital role in the early stage of the pregnancy. So if you talk about more the hormonal changes during the pregnancy, you can see here the first marker when at the beginning of the last menstrual period. So you can see that the hormones like beta hcg, progesterone, and estrogen, these are playing a very vital role in the pregnancy and can also be affect the digestive, circulatory, respiratory, urinary, and muscular systems. So the muscular systems also are impacted during this pregnancy, and their value increase has a different impact. If we talk about the human chorionic gonadotrophin, that's called HCG, or in some cases we call beta HCG. It's a basically initial elevated pregnancy hormones, and that's a rise consistently until after around 10 to 12 weeks of the gestation. So you can see here that's area where the peak level of the human choriogonadotrophin of the gestational weeks occurs, and they tends to the plateau or even drop off. After getting the plateau, they drops off in the rest of the period of the gestational period. The important thing, so for the pregnancy markers, it gives you the early detection. So after it's been reported that after the 48 hours of conceive, like 48, let me change the pen. After the 48 hours of conceiving, this serum marker increase. So this human choriogonadotrophin release in the blood, first in the blood after 48 hours of conceiving. And the urine beta hcg, the urine, the beta hcg detection is little bit late, because once it goes to the plateau in the blood up to some time, and then it start releasing in the urine samples. So after missing the first menstrual cycle, 1 week after the missing of the menstrual cycle, this urine beta HCG is recommended. But if they want to detect the early, the serum beta HCG value helps within the after the 48 hours if it's conceived is expected. So it can be tested by the human chorionic gonadotropins. And according to the manufacturers, these are the recommendation. But in the good laboratory practices, this beta HCG assay is also used for the testicular carcinoma in males. Otherwise, usually this hormones is used to check the pregnancy and the ectopic pregnancy. Other than the uterus, if the pregnancies occurs, that assays helps to diagnose the ectopic pregnancy. So the second marker change or the hormones change during the pregnancy is the progesterone. It's play a very vital role in the pregnancy and then development of the fetus. If the progesterone values are not raised during the gestational period, the possibility of miscarriage and the impact on the development of the fetus maybe occurs. It's basically suppress the immune response of the mother to the fetal antigens. That's a major function of this progesterone. And it's also prevent the rejection of the fetus as well as decrease uterine irritability. So it's also play a vital role between the immune systems and the fetus and the mother immune systems. So if we talk about the another marker which has a significant change during the pregnancy is the estradiol. So the estradiol increases due to the placental production during the pregnancy, and all these three markers are have a clinical correlation with the gestational weeks and the development of the fetus in the early stage, and also have a placental production during the pregnancy. So these are all the changes in terms of hormones values during the pregnancy. So if he goes about the menopausal hormones, so you see that what is the pathology of the menopausal situation? Basically, menopausal transition is a time in which the each woman reproductive life that precede the final menstrual periods. So you know that the early menopausal transition is accelerated through the inhibition B, then the negative feedback to the pituitary and the hypothalamus, and the FSH values increase and earlier follicle recruitment is occurs. So if the menopause is caused by the depletion of the primordial follicles in the ovaries, then the female has a maximum number of oocytes at 20 weeks gestation, and then follicles pool decrease gradually throughout the life about age 52 when the pool runs out. So when this follicle depletions occur, then the recruited follicles, then the most menopausal, then the ovulations decrease, and then the corpus luteum decrease, and the progesterone value decrease, and the lighter bleeds observed. And then maybe some cases there is an ovulation is decreased and the lightening of the cycles is observed. So if we talk about the recruited follicles, then the granulocytes, and then anti-malarial hormones are the best indicators for the follicular reserves. And if we talk about the estradiol decreased values along with the sex hormone binding globulin and the raised value of LH, it's an overall in androgen decrease, but mainly relatively high concentration, which shows you that especially the free testosterone is required. So the early in the menopausal transition, the menstrual cycle becomes relatively shorter and more regular. So the early menopausal transition phase markers are FSH and LH. They both raise during the menopausal transition. Estradiol, anti-malarial hormone, and progesterones are usually in decreasing phase in the menopausal transition phase. So if you talk about the other assays like DHEAS, so what is DHEAS? So DHEAS basically a dehydroepiandrosterone sulfate is basically a male sex hormone that is found in the both men's and women's, but usually in the men's the reference range is higher as compared to the women, and it is produced by the adrenal cortex and the outer layer of the adrenal gland, with the smaller amount being produced by the women ovaries and man testes. So how they are can be also be metabolized by the body in the more potent androgens about such as testosterone and androstenedione. So let's see about the physiology and the biosynthesis of the DHES. So in our body there is a compound that's called cholesterol. Then it's converted into a pregnenolone, and then this pregnenolone converted to using the 17 alpha enzymes, that the 17 hydroxy pregnenolone. And then it's converted into the DHEA, and then DHEA is converted to the DHEAS, which is a dehydroepinoadrenostrone sulfate. This is the journal pathway for the production of DHES from the cholesterol. The other pathway is production of the androstenedione and the estrone and the estradiol through the cholesterol. Then the progesterone not convert into through the 17 alpha to the 17 hydroprogesterone. Then it's convert into using the 3 beta enzymes to the progesterone. And this progesterone has a two pathway, either convert into the deoxycorticosterone, and then the corticosterone convert into the corticosterone, and then the corticosterone with the help of 18 hydroxy enzymes to the aldosterone. So the second pathway from the progesterone to the 17 hydroxyprogesterone is treated with the 17 alpha, and then this 17 alpha hydroxyprogesterone has a two pathway, either to convert into a cortisol by converting pathway to the deoxycortisol of 25 hydroxy by using the 11 beta, and then they convert it to the cortisol. The other pathway of conversion of 17 hydroxyprogesterone to the estradiol and dihydroxystrone or a testosterone is that then this 17 hydroxyprogesterone is converted into an androstenedione with the activity of 17-20 enzymes. Then this enzymes convert androstenedione either to the testosterone or estrone, and then the estrone convert into the estradiol. In some cases, the testosterone is also converted into the estradiol. Otherwise, this testosterone is converted into a dihydroxytestosterone. So these are the pathway of conversion of cholesterol through the enzymatic pathway. That's then from the DHEA4, estrone, and estradiol, and the cortisol and the aldosterone. So through this process, that's occurs. So if we talk about the clinical application and the utilization of these assays, we have the first enzyme that's called luteinizing hormones and the follicle stimulating hormones. So as we discussed in the previously, that what are the role of these two hormones which are released by the pituitary glands, they have to evaluate the health of your reproductive organs or the pituitary function. So whenever they are testing, they helps to distinguish between the pituitary functions and the reproductive organs health. So in children, it is basically these tests are performed to evaluate the precocious or a delayed puberty. So it also helps to determine the diagnosis of polycystic ovarian syndrome. So this polycystic ovarian syndrome is a female disease in which the values are correlate with the PCOS. So it also helps to determine the onset of menopause. So these markers are also helpful for that purpose. If we talk about the PROG, that's called a progesterone, it helps to diagnose the miscarriage and the ectopic pregnancy, which is other than the uterus. If the placenta is developed, we call them an ectopic pregnancy. If we talk about the cause of the infertility and the abnormal uterine bleeding, is also monitoring through the progesterone level. And the monitoring of the pregnancy and the decline of progesterone is and may indicate the early abortion indicators, and also the progesterone replacement therapy monitoring for to retain the pregnancy in those women who have this hormonal imbalance. If you talk about the estradiol, that's an estradiol. It's a monitoring the treatment for the infertilities, and then that helps to determine the onsets of the menopause. So it's also a support to have a monitoring of infertility and the menopausal along with the beta HCG. It helps to confirm the pregnancy after conceiving 48 hours. And then it also helps to diagnose the ectopic pregnancy and the risk of the abortion in different cases. And also helps the testicular carcinoma for the male. But according to the manufacturers, this is not in the claim of these assay that it can be used for the testicular carcinoma. But according to the good laboratory practices, the labs are using the values of the beta HCG for the male if their values are highly elevated. So the probability of that diagnosis of testicular carcinoma is observed. So if we more talk about the prolactin, so in the prolactin, we have it's basically the female hormones, which is helps to investigate the unexplained flow of blood, breast milk. Any question? HCG can be used as an oncological marker, not for the oncological marker. In some countries, the laboratory use the value of beta HCG for to rule out the testicular carcinoma. But according to the guidelines in any company like Roche, Abbott, Siemens, and the SNIDE, it's not mentioned that the beta HCG test value can be used to rule out the testicular carcinoma. But it's an observe during the testicular carcinoma in males, the beta HCG values are increased. But it's if in the IFU in the package insert, it's not claimed. But it's in the good laboratory practices, some labs are using this assay for that male diagnostic tool. Right? They have no clinical significance in other oncological markers except this typical case that's I have observed in diagnostic laboratories for that. And the prolactin in male, it also helps to diagnose. I hope I give you the right answer. If everything is clear, we can proceed further, or you need some more clarity. Artem, you're in. So is it okay? I give you the sufficient information, or if you need more, you can send me the message, right? Okay. So the next is the prolactin. It's also in a male if the prolactin values helps to diagnose the decreased libido and the erectile dysfunctions. Along with that, it also helps to detect and monitor the pituitary tumors. And the pituitary tumors, there's a typical picture of prolactinoma, basically. So if we talk about another fertility markers with the which is okay, thank you. Thank you, Artem. So in a male, they have helped diagnose the cause of erectile dysfunction or infertility, along with the female if they have a cause of virilization and they have infertility or a polycystic ovary syndrome, PCOS, and then in children, they also helps to determine the cause of delayed and precocious puberty. So if you talk about the DHES, that's an help to whether the adrenal glands are working properly, and then the adrenal tumor detections or the carcinoma is also a special marker for this adrenal tumors using this DHES markers. So if we talk about the determination of virilization in the girls and in the women, precocious puberties in the boys, that may also can be helpful using this analyte for the detection of these different diseases. So let's talk about what are the common gonadal diseases. So these are the few examples of gonadal diseases like precocious puberty and the abortion and the ectopic pregnancy and the male hypogonadisms. So basically, these are the male-related diseases. If we talk about the polycystic ovarian syndrome and hyperprolactinemia, along with the hirsutism and the virilization. So these are the common gonadal diseases. We will discuss one by one in the next slides. So let's talk about the precocious puberty. So the precocious puberty is when a child body begins changing into the adult, the puberty too soon. The puberty is marked by the physical changes, which have such a growth of the public hairs, the breast development in girls, and the testiculars development, and the penile enlargement in the boys. So this is called the puberty markers in terms of physical change. If we talk about the girls, they have a typical developed signs of puberty between the age of 8 to 13. And in the boys, they have start puberty within the wide range of age. But most boys start puberty after the 10 years old. So when the puberty begins before the age 8 in the girls and before the age 10 in the boys, it is considered precocious puberty. So this is important. So when the female sexual characteristics develop, like the breast budding, public hairs, growth spurts, peaks, change in the habitus, menarches, axillary hairs, and the adult breast, that you can see that's the characteristics of sexual characteristics develop in the females between age 8 to 9. The breast budding, the public hairs are increased. So if you talk about age wise, there are different increase in the sexual characters development. If we talk about the male sexual characters development, like testes, public hairs, lengthening of the penis, change in the voice, growth spurts, peaks, change in the habitus, facial hairs, and axillary hairs. There's the occurs after the 10 years of age. You can see that between the 11 years they have been changed. There is the testis and the pubic hairs, along with the lengthening of the penis, and the change in the voice is occurs at the age of 11 years, or after 10 and a half years. So you can see that these are the values, these are the sexual characteristics, male sexual characteristics development at the different ages of 10 years, 12 years, and 14 years up to the 18 years. So this between the age 8 to 13 in the girls, and between age in the boys between 10 to 18, these changes in terms of male sexual characters developments occurs. So if we talk about the possible complications of the precocious puberty, which include the short height, the social and emotional problems. And if we describe about the short height, it can cause child with the precocious puberty to be the shorter than average when an adult. So if the height is lower than the expected height, is considered as an precocious puberty, and it may have affect self-esteem and increase the risk of depression or the substance abuse is more in that. That's why they call them social and emotional problems. So we can classify or differentiate the precocious puberty into two types. One is called the central precocious puberty, CPP, and the other one is called peripheral precocious puberty, PPP. So the secondary sexual development trace the hypothalamus or the pituitary. In its means it's an gonadotrophin releasing hormone dependent. That's why they call them a central precocious puberty. While the peripheral precocious puberty is a secondary sexual development which is induced by the sex steroid from other abnormal source. It's independent than the gonadotrophin releasing hormones. So there's no involvement of GnRH in the peripheral precocious puberty. And let's we see more about these central precocious puberty and then peripheral. So the precocious puberty differential diagnosis is based on these different testing. Like if there's any clinical evidence of the pubertal signs in the girls, less than 8 years, then the basal luteinizing hormones, and the LH value is less than 0.2, and then the LH value is greater than 0.3. And then if the LH value is less than 0.2, excuse me, then it's a less than 0.2, then the clinical evaluation for the peripheral precocious puberties is required, and then expected there is no progression in the puberty, then the follow by the 6 month. After the observe, it's a 3 to 6 month, no pubertal progression or a pubertal progression is occurs. If no pubertal progression is occurs, observing after the 3 to 6 month, then observe may not be a variant referred to the pediatric endocrinologist. And then if there is pubertal progressions occurred, then consider the gonadotrophin releasing hormone stimulation test to stimulate LH if it's less than 5, or if it's greater than 5. It's a greater than 5 stimulation, then it's considered as the precocious puberty suspected if the estrogen is elevated. So if the LH value is 0.3, then the expected there to be progression in the pubertal status over the following 6 months. Then the CPP suspected if the estrogen is elevated, depending on the clinical variables. That's an imaging, MRI, gonadotrophin releasing hormone treatment against in case, and then it helps to diagnose the precocious puberty differential on the basis of that LH and the further investigation of different analytes through this. So if we go for a further explanation of different diseases like gonadal disease, like male hypogonadisms. In this male hypogonadism is a clinical condition in which they have a syndromes like a failure to produce physiological concentration of testosterone and normal amount of sperms, or maybe some cases the both. So what are the symptoms of hypogonadism in male? They have a decreased development of the fetal and the decreased secondary sex characters. They have impaired growth of body hairs. They have erectile dysfunctions. So the other subtypes are the primary hypogonadisms and the secondary hypogonadisms. So let's talk about the first, the normal hypothalamus pituitary gonadal axis. So what is the normal hypothalamus pituitary gonadal axis? And you know that the hypothalamus is neural tissues which release the hormones, that gonadotrophin releasing hormone, and then they have a two part, the anterior part and the pituitary part. And then you know that the anterior part is releasing these hormones of LH and FSH, and these LH and FSH helps to release the testosterone and sperms in a male. So if you talk about the differentiation of that, the primary hypogonadism or a secondary hypogonadism, the anterior pituitary part of the pituitary gland is releasing more luteinizing hormones and follicle stimulating hormone, and then it's released the more testosterone and then sperms. So if the secondary hypothyroidism, they have released the LH and FSH in a less amount, so the less testosterone and sperms are released. So this is about the primary hypogonadism and the secondary hypogonadisms in this case. If we talk about more the male hypogonadisms, so you can see that causes of the male hypogonadism and the infertility. If we review the cause of the infertility, you can see that the infertility globally, the 30% related to the male, and females are also 30% infertilities are related to the females. The 10% cases probability, the both male and female partners have some infertility or complications, and the 25% is still unexplained, and the 5% are have other infertility causes in this cause of male infertilities and the female infertility. So the 10% of male infertility is caused by the hypogonadisms. So the 30%, only 10% is caused by the hypogonadisms, while the varicocele is by 17%, and then unexplained is still at 34%. The other cause are 18%, and the systematic disease 3%, sexual factor 6%, urogenital infection 9%, undescended testicles is 8%. So you can see that the male hypogonadism is just a 10% of that 30%, which is a cause of male infertility. So if we talk about the algorithm for the rule out of male hypogonadisms, so according to this publication, this clinical utilization and the diagnosis of hypogonadism is made on the basis of the sign and symptom consistent with the androgen deficiencies, which means the low morning testosterone concentration in serum and the multiple location, it may leads to the male hypogonadism. So the sign and symptoms are of hypogonadism, and if the major total testosterone concentration in the serum in the morning with a reliable assay, if the total testosterone value is between 9.7 to 10.4. This repeat the measurement of total testosterone and measure the free testosterone and SH by a BG variation expected. So if this total testosterone and the free testosterone value is between 9.7 to 10.4 and 0.17 to 0.31, that's major LH and FSH. If the LH and FSH values are high, that's the primary hypogonadism. If the low or inappropriate normal LH and FSH concentration, it's considered as a secondary hypogonadism. So the further testing is required, maybe some iron studies, karyotyping to rule out the Klinefelter syndromes, especially the in the males when in the further testing for the secondary hypogonadism is the prolactin, iron studies, pituitary hormones, MRI, or excluding use of opioids and glucocorticosteroid. If the testosterone value measurement of the early morning with a reliable assay is a normal, then the hypogonadism is unlikely. Reassure the patient and the follow-ups for the further investigation if they have any symptoms of hypogonadisms. So for the male hypogonadisms, according to the Journal of Clinical Endocrinology and Metabolism, volume 103, issue 5, May 2018, they have a clinical practical guideline for the testosterone therapy in men with hypogonadism. And Endocrine Society is a clinical practical guidelines. And according to these guidelines, patient with the male hypogonadisms often require testosterone replacement therapy, which involve the exogenous testosterone supplementation, then eliminate the physiological changes and the clinical symptoms caused by their testosterone deficiency. So these testosterone level may also need to be monitored regularly to confirm the treatment of their effectiveness and all. So those patients who have a male hypogonadism and they have the physician prescribe the testosterone replacement therapy on the basis of the diagnosis, they need the monitoring and the prognosis of this hypogonadisms is having an exact dose, or they need maybe adjustment in the dose as well. So in women, there is a gonadal dysfunction is a polycystic ovarian syndrome. So what is the polycystic ovarian syndrome? It's basically an hormonal imbalance resulting in the lack of ovulation, irregular period, and the infertility. So almost 85% of ovulatory disorder causing the female infertility is due to the PCOS. So in the men, as we discussed, this 30%, are the infertilities in the man's and 30% the female. And this 30% female cause of fertility is around 40% is ovulatory disorders, while the 40% is tubular factors and the 15% is still unexplained, and only the 5% is uterine factors related to the infertility in females. So if we more have a detailed cause of female infertility in terms of 40% ovulatory disorder of 30% of overall cause of infertility, the 85% is polycystic ovarian syndrome, and only the 15% is the other cause of infertility in female. So, what are the diagnosis tools that can be used for the diagnosis of PCOS? So, the polycystic ovarian syndrome diagnostic common characteristics have a multiple small cyst, which have aligned with the outer capsule of the ovary with an appearance of a chain pearl on ultrasound. So, you can see here this is an anomaly in normal ovary. So that's an corpus valens and the corpus luteums, and then the ovulation is released, and this fallopian tubes through this fallopian tubes released into the uterus. So, but in the polycystic ovarian, you can find here chains of the pearls found on the outer capsule of the ovaries, and in the ultrasonic imaging of the polycystic ovarians, that is it looks like this. So this is the imaging or the radiological image and the common characteristics of the polycystic ovarian syndrome. So if you talk about more the clinical symptoms, what are the clinical symptoms in the women's about the polycystic ovarian syndrome? It's basically a normal interaction between the different behaviors, environmental and genetical factors, and the main clinical symptoms with the almost 70 to 80% of women are presenting with the oligomenorrhea or amenorrhea. You can see here that's called irregular menses, and in some account of the 90 to 95% of women having attending the infertility clinic with anovulations. So the stopping of the ovum production is called anovulation, and then the obesity is also one of the factors. You can see here that may lead to the hyperandrogenisms and then hyperinsulinemia. So these are the factors which have clinical symptoms like hirsutism, acne, infertility, polycystic ovarians, mood disorder, depressions, and the nigricans, and the neck region, the obesity and alopecia, and the irregular menses are also the signs of PCOS. So in the hyperandrogenisms, there is an acne and seborrheas and hirsutisms cases are there. And for the hyperinsulinemia cases, that the insulin resistance occurs in 50 to 80% of women with the PCOS. So for the polycystic ovarian syndrome, the utilization of fertility markers along with the insulin marker has an clinical utilization for the rule out of PCOS in the woman. So how the excess androgen causes the PCOS? So you can see here in the abnormal menstrual condition, that you can see that this follicle ovarian syndrome, follicular phase, when the FSH and LH are released, they have impact on the T cells, and then they release the too much androstenedione, then that's convert granulosa cells to estrogen, and then the blood release abnormal menstrual conditions as occurs. So in the ovulatory phase, that you can see that there is no trigger for the dominant follicles. No ovulations occurs because that estrogen levels is the negative feedback mechanisms stop the production of the FSH, and then no LH surge, so they're not well understood. So the no triggers of the dominant follicles and the cyst degenerated, and there is no ovulation that occurs during this ovulatory phase when the PCOS occurs. So if you go for more about the PCOS diagnosis, according to this guidelines, that the diagnosis is in a pelvis examination through the follicles in the ultrasound, not necessary for the diagnosis, and maybe some blood testing like LH and FSH values are higher along with the androgens values are increased. That may help to diagnose for the PCOS. So if you talk about more the PCOS diagnosis, according to the ROC curve for the hormonal levels in predicting polycystic ovarian syndrome, you can see that there is testosterone, androstenedione, LH-FSH, and the baseline is here. The excessive androgen in the PCOS aviation, like testosterone and androstenedione. In healthy women, the ratio between the LH and FSH usually lies between 1 and 2. But if the polycystic ovarian syndromes women suspected, the ratio becomes reversed and it might be higher than 2 and 3. So the testosterone AUC values is 86.1%, androstenedione AUC value is 84.7%, and the LH and FSH ACU values is 82.1%. So through this process, the PCO diagnosis has helpful with different clinical assays utilization. So if we talk about the hyperprolactinemia, if the serum prolactin level is increased or higher than the normal levels of prolactin in the bloodstream, it's called hyperprolactinemia. So basically, the hyperprolactinemia is a hormone imbalance condition, and this prolactin is basically a hormone which is made from the pituitary gland anterior part, and this excessive production of the prolactin can lead to the infertility and the gonadal dysfunction. So this is the color scan showing a side view of the tumor of the pituitary glands, and then this the prolactinemia secreting pituitary tumors that's maybe occurs due to this cause. The condition is maybe pituitary tumors, and in the pregnancy or a breastfeeding, it's also increased. And is also in case of hypothyroidism, stress, renal failures, drugs, and in co-secretion of prolactin in acromegaly cases as well observed. So what are the clinical symptoms of hyperprolactinemia? So as you know that the hyper means high, prolactin is an hormone, and anemia means in a bloodstream. So for the unisex, there is a vision problem, headache, and decreased libido is all the early marker for the hyperprolactinemia. In the male, the breast enlargement, erectile dysfunctions are the early clinical symptoms for the hyperprolactinemia. In the female, milky nipple discharge, menstruation cycle, brittle bone at the old age is also a best example of hyperprolactinemia condition. So if we talk about the algorithm of hyperprolactinemia, so you can see here the overview of the diagnosis and the management. In the normal serum prolactin level, which may varies from 5 to 25 ng per ml in the females. So you know that the serum prolactin levels are usually higher in the afternoon than in the morning, and it can be preferably measured in the morning. So the hyperprolactinemia is usually as defined as the fasting condition of above 20 nanogram per ml in the men and above 25 nanogram per ml in the woman, and after at least 2 hours awake after waking up. So this is peak levels and in the morning levels, and in the prolactinemia, in the condition in which the greater than 250 and 500 milligram in the diagnosis of the macroprolactinemia. So the hyperprolactinemia on the basis of the history, drugs use, and physiological and etiological distribution. They have to repeat with the new one values. If it's a normal, it's okay, but if it's an elevated value of prolactin, then go for the TSH. If the TSH is also elevated, then treat the hypothyroidism, due to which the hormonal imbalance in terms of fertility markers maybe occurs. So you have to repeat the prolactin and the TSH after 6 to 12 weeks, and then document resolution as well. So if the TSH values is normal, only the prolactin values are elevated, then the MRI or CT scan is recommended, and on the basis of this MRI and CT scan can be go for our hyperplasia, the microadenomas and macroadenomas, and further clinical investigation, and the medical management is required to treat that differential diagnosis of the microadenoma, macroadenoma, and the hyperplasia. So if we go for another syndrome like the hirsutisms and virilization, let's talk about what is hirsutisms and virilization. As you know that these are the reflects the excessive androgen production in generally the females individual has a characterized by the excess male pattern of the hair growth. So these are the specific characteristics of the hirsutism and virilization. In hirsutism is generally increased body hairs, non-sexual hairs, especially the facials and on the bodies or on some other parts which are non-sexual hairs, which are other than the private parts. So there's a face, chest, abdomen, inner thighs, and in the virilization, there's a deepened voice, clitoromegaly, are also that's the early indicator of the virilization. So, what are the six main causes of hirsutism and the virilization? Maybe the polycystic ovarian syndromes, then ovarian cancer, Cushing disease, adrenal carcinoma, and the congenital adrenal hyperplasia, and the idiopathic hirsutism, which have above cause been ruled out. This is all the six major causes of hirsutism and virilization in male and females. So, what are the causes of hirsutism and virilization? High testosterone level, condition called hirsutism. In polycystic ovarian syndrome, it's called a multiple immature follicles found there, and the patient with PCOS have a high testosterone level, but will have also have LH and FSH ratio that is all elevated. In the ovarian cancers, there's a normal ovary. This is an ovary with the abnormal cells growth. That's called a cancerous cells, which has a highly, extremely high testosterone levels. And that's the transvaginal ultrasound or the CT scan of the abdomen and pelvis also used to look for this ovarian mass to rule out the ovarian cancer. So if you go for the cause determination of this hirsutism and virilization, you can see that with the Cushing disease, the problem lies in the anterior pituitary, and this may lead to the elevated DHS values, ACTH increase, and the increased cortisol levels may lead to the Cushing disease. So the high DHSA levels that cause hirsutisms may be a Cushing disease, maybe adrenal carcinoma, or maybe congenital adrenal hyperplasia. So with different assays and the values on the basis of which the negative feedback on the anterior pituitary, the adrenal carcinoma can be ruled out. For the congenital adrenal hyperplasia, this is basically a 21 beta hydroxylase enzymes deficiency, which may lead to the production of the cortisol is decreased, and this decreases the negative feedback mechanism to the anterior pituitary, and then due to this increased ACTH level. So the DHESA levels will be elevated during this congenital adrenal hyperplasia, and patient with CAH has an elevated 17 hydroxy progesterone levels. So these are all the other assays correlation in terms of directly and indirectly with the DHES, and then the rule out of the different disease of CAH, adrenal carcinoma, and the Cushing disease. So, what are the cause and the determination of hirsutisms and virilizations? So, any question? Okay. Okay. So, if you talk about any possible cause of hirsutisms and corresponding lab tells difference, like if you talk about the different conditions like polycystic ovarian syndrome, cancer, ovarian cancers, Cushing disease, adrenal carcinoma, and CAH. So in this levels, different analytes have a different clinical utilization. Like testosterone, excuse me, the testosterone and LH, are increased in polycystic ovarian syndrome. In ovarian cancers, the testosterone levels have increased, but they have some variation in the testosterone level, while the other assays has no clinical significance in this ovarian cancers. Just to rule out the Cushing disease, the DHES values is increased, the cortisol values increased, and also the ACTH values increased during the Cushing disease. For the adrenal carcinoma, the DHES and cortisol values are increased and the ACTH values are decreased. So these are the possible diagnosis on the basis of clinical evidence and the other confirmatory testing that this is an adrenal carcinoma. For the CAH, the DHES values is increased with the ACTH value, only the cortisol values is decreased in CH condition. So there are few analytes like testosterone, LH, FSH, DH, cortisol, and ACTH have a different utilization in combination and individually for the different conditions rule out of male and female as well. So if we talk about more the Maglumi gonadal parameters, what the SNIBE is offering from that platforms. So we are offering okay. So we are offering LH, the luteinizing hormones. We have a two generation of LH, the first generation and second generations, and we have a both generation have a 100 test and 50 test pack size. We have a sandwich quantitative analysis. We have an upgradation in the second generation of serum and plasma, both as compared to the first generation having only a recommended sample type was a serum. We have a traceability in terms of standardization, which is the WHO's second international standard 80 by 552. We have an upgrade, the second generation LH with the third international standard 81 by 535 for the traceability and the reliability of the assays. We have a calibration interval of 4 weeks. We have a minimum sample volume along with the concept that we have a concept of LOB, LOD, and we have a linearity of 0.5 to 250 micro IU per ml. So the onboard stability is 1 month, and the internal QC levels improved in the second generation. We have a minimum of 2 level of QC available with the free of cost calibrator with the reagent in LH second generation. So if we compare the LH second generation on the basis of commercially available samples, We have run 38 number of samples in comparison with the commercially available LH analyte. They have the excellent correlation of 0.99% regression value with the p-value of less than 0.001, and we are equally good in terms of assay performance, reliability, and then performance levels. So if we talk about the FSH, we have two generation, the generation 1 and the generation 2. This generation 1 and 2 have 100 test and 50 test pack size. They have a sandwich quantitative analysis. In second generation, we have an upgraded version of serum and plasma, both sample type recommended. We have a same traceability of first generation, WHO first international standard by the 92 by 510 values. And then we have a calibration interval of 4 weeks. It means if you have load the reagent on an systems, it's these are stable up to the 4 weeks. So the sample type is just a 40 microliter, and on the basis of LOB and LOD, the linearity is between 1 to 200 micro IU per ml. So the onboard stability is a 1 month, and we are providing free of cost internal quality control of at least 2 levels along with the second generation of FSH assay. So if we compare the SNIPE follicle stimulating hormone second generation with the other commercially available markers, so you can see that the SNIPE FSH value on the basis of run of 51 samples, uh, 51 samples, the regression value is 0.99, the p-value is less than 0.001, which shows the excellent correlation between the reference commercially available reference instrument assay versus the SNIPE FSH second generation assay. So if we talk about the prolactin, we have a 2 generation prolactin. This first generation prolactin has an same 50 and 100 test by sandwich quantitative and the improvement in the sample type. In the second generation, we have an upgraded to the plasma sample type along with the serum, which was also mentioned in the first generation. We have a standardization improve according to the WHO internal standard guideline 83 by 573. We have done a traceability and calibration of our assay with that traceable material. The calibration interval, you can see, okay, there is a data with whom estradiol was compared. Okay. So your question is about the estradiol, to whom it's compared. Usually, the SNIPE is has a comparison with the Roche in the fertility markers, but I need to make sure that which other in this estradiol comparison, which we have a comparison exact competitors comparison, right? Need to comparison. Okay, for the LH. Okay. For the LH, usually we have a comparison with the Roche. But in some cases, we have also comparison with the Abbott, with the Siemens. But usually we have a more of them. The reference commercially company are Roche. So, but let me confirm with my team leader that the LH comparison is data with which company, right? So you can see here that in the prolactin, we have a 0.99% regression value and 0.001% p-value on the basis of 54 samples from the low range to the high range with the commercially available prolactin assay. So these prolactin, progesterone, FSH, LH are mostly the Roche analytes. But if you need an exact more confirmation, I will let you know. So if you talk about the testosterone, we have a 2-generation testosterone values we have a 50 test and 100 test spec size. We have a quantitative competitive principle. We have a both serum and plasma sample type recommendation. So the traceability is the USP reference standard that we are using for the standardization of the testosterone level. The sample volume is just 20 microliter, and we have a linearity of 0.25 to 17 nanogram per ml. Onboard reagent stability is a 1 month, and with the second generation, we have an upgrade of having a free of cost, at least 2 level of QC are provided as a single and light for the testosterone levels. So if we see more about the comparison of testosterone with the commercially available, other commercially available markers like the testosterone of other competitors. So on the basis of 99 samples run, their regression value is 0.99, which shows the excellent correlation with the reference instrument, which are usually Roche. So if we talk about more the excellent correlation with the progesterone, yes, we have a 2-generation progesterone values, which has an 50 test and 100 test. We have a competitive and quantitative analysis. Through this, we have a serum and plasma. Both types are recommended in the 2nd-generation assay. We have a USP reference standard material, while we have a calibration interval of 4 weeks. And the sample volume is just 9 microliter, and our assay's linearity is 0.2 to 80 nanogram per ml. So we have a limit of blank, and limit of detection is also mentioned in the 2nd-generation, which is improved as compared to the 1st-generation. The onboard reagent stability is a 1 month. In the 2nd-generation, we have an improvement of 2 level of QC for the progesterone assay, while in the 1st-generation, we have only the 1 level of QC. So this is again a comparison of SNI with other commercially available progesterone in the market, and it shows an excellent correlation on the basis of regression value of 0.98, and on the basis of 115 samples from low values to the high values has been evaluated to check the performance of the progesterone assays. So if we talk about more estradiol. So then the estradiol, there's a 2-generation that we have from the SNI platform and the Maglumi analyzers. The 1st-generation has an effect size of 150, which is equally good as compared to the 1st-generation and 2nd-generation. We have a quantitative analysis, and we have improved from competitive to the sandwich principle in the 2nd-generation. We have a both sample type, serum and plasma. We have an internal traceability and the standardization with the USP reference standard. With the calibration interval of the 4 weeks, we have a sample volume of just 20 microliter. We have a limit of blind and detection concept, and we have a broad measuring range in terms of 10 to 4,800 picogram per ml, while have a 6,000 linearity was acquired with the 1st-generation analyzers. So we are offering free of cost 2 level of QC along with that estradiol 2nd-generation that we have in the market. So we have this excellent correlation on the basis of regression value and the number of samples. Our assay is equally good to the gold standard for the estradiol. So if we talk about the Maglumi HCG, you can see that we have a 1st-generation and 2nd-generation. We have a 50 test and the 100 test spec size is available. This is a sandwich, a quantitative analysis, and then they have a serum and plasma. Both are recommended in the 2nd-generation. We have a beta HCG standardization against WHO 5th International Standard 07364. We have a calibration interval of 1 month, 50 microliter, and we have a linearity is the 1 to 5,000. And the onboard stability of the reagent is 4 week. In the second generation, we have improved the number of quality control to validate the assay performance in the lab. On the basis of that, at least 2 level of QCs are recommended according to the guidelines. So we have an excellent correlation with the commercially available beta CG assays. Their regression value is 1.0 on the basis of 72 samples run. On the basis of 72 samples run, and the p-value is less than 0.001, which shows an excellent correlation between the total beta ICG of SNIPE second generation versus the commercially available other beta ICG assays. So if we compare the DHESO4, so this DHES is basically we are providing 100 test and 50 test pack size along with the competitive and quantitative analysis, and the edge is serum and plasma, both sample types, and the 2 level of QCs are available free of cost. We have a 4 weeks improved on board calibration interval, and then with the 10 microliter samples, we have a broad measuring range from between 4 to 1500 microgram per DL. And after the calibration, the reagent is stable up to the 1 month in both first generation and the second generation here. So if we compare the DHES with the other commercially available DHES assays, so the regression value is 0.98 with the N value of number of samples run was 56 with the P value of less than 0.001, which shows the excellent correlation between the SNIPE DHESA versus the commercially available lab. So the other thing, FDA approval. So that's called FDA 510K cleared. So our meglumi, beta ICG, thyroid marker, and few fertility markers are FDA approved. So this FDA 510K number is K19257. So these are available on the sites of US Food and Drugs. So if you talk about the gonadal panel and the other competitors, so you can see here in a SNIPE, we have a very comprehensive menu for the gonadal panels. So if we compare the FSH, we have a commercially available comparison with the Roche, with the Siemens, with the Beckman, and the Abbott, and the Disorin. So in usually cases, we compare our assay performance with the Roche, and in case of Roche is missing, we follow the Siemens, or maybe in some cases we are having a configuration or a comparative correlation study with the Abbott as well. In very few cases, we have a Disorins and the Beckman, in which that like androstenedione and the other assays which are not available from the automatic platform. So we prefer to use the biomimetics like anti-malarial hormones we have with the Roche. So we have a standardization with against the Roche for the correlation study of that. So that's the very comprehensive menu like FSH, LH, prolactin, progesterone, estradiol, beta CG, testosterone, DHS, SHBG, 17-hydroxyprogesterone, androstenedione, free testosterone, and anti-malarial hormone. So the Roche even has missed the 17-hydroxyprogesterone, and the free testosterone is also missed from that platform. And the few markers like androstenedione is also have with the Roche and Siemens. The Abbott has a big menu missing part along with the biomimetics, and then the other Beckman they have. So if we talk about the Roche and the Siemens, they have just two missing analytes, 17-hydroxyprogesterone and free testosterone. But as of today, the SNIPE meglumi has the broadest menu for the gonadal parameters. So that's all about today's. So if you have any question, you can ask. Just give me a 1 minute, so I have to take one picture. Just give me a 1 minute. Okay, so we can take a break. So we can take break. 10 minutes or a 15 minutes, what you want? 15 minutes break is okay for you? Okay, so we will meet after 15 minutes. Okay, thank you.